So I'm going to turn it over to Dr. Levin.
Thanks for the best introduction ever. I love that. You weren't uncomfortable enough. So I am Dr. Levin. I work in the same program as Dr. Shumay, and I'm actually happy to be here today to talk a little bit about promoting sexual wellness and healthy body image after cancer. And one thing I want to say to begin with is that, of course, sexuality and body image means different things to different people. And the changes that you're going to have in it are going to depend a lot on your unique situation and the specific treatments that you have undergone and what's going on in your life outside of it. So today is really meant to be an overview. It's another thing I want to put on the table to make sure you know that if you are seeing changes in this, you are not alone. You are far from alone. I'll talk about that. And not only that, but there are things you can do about it. And often that's a bit of a novelty for folks at this point in treatment. I do want to acknowledge these groups and individuals because their work has really contributed to today's presentation. So I'm going to start to talk about how cancer and its treatment can influence or impact sexuality and body image. And then I'm going to start to introduce some of the things that you can do to help. Again, an introduction today is what it's meant to be. So I wanted to start, just like Dr. Shumay did actually, I wanted to make it a little human by talking about some of the sorts of things I've heard from patients over the years. That may or may not sound familiar to you. I've had folks come in and say things like, right now in this moment, I feel like I'm not the same person that I was before cancer. I've had folks say that sex has become painful since they started treatment. So it's kind of fallen off because why would I want to keep doing it if it hurts? I've had folks say things like their day-to-day functioning, what they want to do in their lives have changed a little bit because they don't want other people to see their scar or how their body has changed. I've also had folks say things like, sometimes I look in the mirror and I don't see myself right now. Folks also talk about how other people might react to changes that may be visible, concerns that other people will notice changes in how they look and that there'll be judgments associated with that, or pity. I hear a lot sometimes about concerns about pity as well. I hear people talk about how their sex lives has changed since diagnosis and treatment, and they're not sure how to change that. They're not even sure how to bring it up sometimes with their partner or partners. And this is what I hear a lot. I don't know if this rings true for anybody, but some folks saying, I started this treatment like feeling like I was a certain age, like I fit the number or even felt younger than that. And now I feel like somehow I've aged quickly and prematurely. A lot of folks talk about that sense. I also have folks being concerned about how other people, especially kids, react to changes in their appearance. Especially the scar, if that's visible, but any appearance changes. So I don't know if any of these fit for you, but I just wanted to give you a sense of what this might sound like, the types of changes we're talking about. And I think if you look at these examples or think about them, they really capture the fact that there are many different aspects of our lives that relate to sexuality and body image. And of course we talk a lot about the biological or physiologic changes that come from treatment, and I think that's important. But I think what can get lost in the wash here is how it's a bigger picture, it's a larger model of what impacts our sexuality and our body image. So it can be things like what's going on psychologically. If we're concerned about changes in appearance, if we're concerned about potential changes in how we're functioning, of course that can impact what's going on in the system. There's also the interpersonal changes, and Dr. Shumay touched on some of those. But there could be changes in romantic relationships that occur with cancer diagnosis and treatment. There can be intervals of abstinence during treatment that can also have impacts, as well as things like the life stressors and financial stressors that can come along and often do come along with cancer diagnosis and treatment. We all know that getting to the UCSF Cancer Center can be difficult at times. especially when beta breakers is going on, say. All of those types of stressors also influence the whole system here. Another thing to keep in mind is that we all kind of bring to the table different ideas about how we should feel about ourselves, ideas about sexuality that come from our socio-cultural upbringing, and that those are also a huge piece of the picture here. So as we move forward here, I just want us to keep this larger model in mind, that it is this dynamic thing. Sometimes when we talk about sexuality or body image, we really focus on physiologic changes, and I think we end up doing ourselves a disservice there, because it really is this whole picture. So I want to start by talking about some treatments that are out there and how they can affect sexuality and body image. I want to keep in mind, though, that this is a time where this is very general, and it really depends on the exact specific treatment that you received. So this is quite broad. But let's start with surgical treatment. Surgical treatment can affect, of course, our body image and our sexuality because of structural changes that may occur. There could also be changes in sensation, so changes to nerves, and that can really affect sexuality and body image. Also, if the treatment has ever required an ostomy, that can have a big effect on body image as well, and sometimes be a little logistically tricky when you're talking about initiating intimacy, physical intimacy. In terms of endocrine treatments and hormone treatments, these are any types of treatments, they might be surgeries or medication, that have an effect on hormones, either how much they're produced or the actions that they have. And this is the type of treatment that can cause hot flashes, things like that. And those can definitely have an impact both on self-image and on sexual functioning. We'll talk more about that. Chemotherapy. Chemotherapy, a heavy hitter here is fatigue, which I know you probably don't need me to tell you, but let's emphasize it. And fatigue is something that can impact our functioning overall. And certainly our how we feel about ourselves when we're feeling that tired and maybe not able to do some of the things that we like to do while we're experiencing that fatigue. Also, certain chemotherapies can actually have an impact on the gonads. So they can actually have an impact on estrogen production, testosterone production. So those can also, over time, have an impact on sexual functioning as well. Radiation treatment is another thing where you can get a lot of fatigue. And also, if it's pelvic radiation, radiation to the pelvis, it really depends. But it can also have an effect on the ovaries in women and cause changes in hormone production again. Or in men, it can also cause changes in erection. And again, that really depends on the type of treatment you've received. But of course, all of this is very focused in on the physiologic side of what's going on. But there are tons of other possible changes after cancer. And I think one thing that can really have an impact is general functioning changes. So if you have changes such as fatigue, if you are kind of experiencing some of that cognitive fuzziness that we'll talk about later today, that can come along with treatments, that's going to have an impact or can have an impact of how you think about yourself and what's going on in terms of your relationship functioning or your intimacy with a partner. And one thing that's tricky about this, and Dr. Shume really touched on this, so I think we touch on this a lot during our Psycho-Oncology work, is there can be a lot of uncertainty around how, when, and even to what extent you might see a symptom of a change in functioning go away, or go back to baseline. So say fatigue. It's really hard to understand how long it might take to feel like you're back to your normal energy level. There can be a lot of uncertainty around that, and that makes it really difficult. And that's definitely something that has an impact on how we think about ourselves. There could also be role changes in relationships during treatment. I don't know if any of you have experienced this, but it could come across in like who's doing the dishes, who is cleaning up the house. But certainly there can be a shift where there's more of a caregiving role that is going on for a romantic partner. And that can be a big change in the relationship. So trying to kind of shift back and reintroduce intimacy can be a challenge at times. And previous sexual routines might be less workable. And with that, there can be lots of difficulty reinitiating and re-engaging in sexual activity because we all like our routines, regardless of what area of our life it is in. And so it can be hard to think about, is there a way to do this differently now or accommodate any changes I've experienced? And all of these changes can lead to kind of a loss of confidence or a change in confidence, as well as changes in how we view ourselves. So what I'd like to do now is going to share some information about certain changes in sexual function that you might notice that can sometimes occur after cancer diagnosis and treatment. But first I want to define a few terms. I have found that sometimes people kind of launch into talking about this stuff without defining the terms that psychology and medicine use when they're talking about sexual functioning. And what is sexual interest or desire? This refers to desire for sexual activity, or sort of how much we think about sexual activity, fantasize about it, have erotic thoughts. But something else that people also talk about when they're talking about desire or interest is an idea called receptiveness. This is just how we respond when someone else initiates sexual or intimate activity, right? How receptive we are at that moment to that someone else reaching out and requesting this. Arousal is a term that's used to describe the physiologic changes that occur as we're becoming more excited in a sexual encounter. So this is like changes in heart rate or flush or your breathing rate increasing. It's also physiological changes involving blood flow to the genitals, right? So if there's changes in erection, people will be talking about changes in arousal. That's the term that will be used. Also, vaginal lubrication in women, that's part of arousal. So when folks talk about that, they'll be talking about changes in the arousal part of the sexual functioning cycle. There's also orgasm. Orgasm is actually harder to define than you might realize. It's the peak of sexual excitement or sexual climax. And it's sometimes, but not always, associated with ejaculation in men. So I just wanted to define some basic terms, and to say that if you think about this, of course this cycle is going to be affected by many of the changes we've already discussed. Vaginal muscles. It happens in the context of a person that's a part of a relationship. So I just wanted to define some basic terms, and to say that if you think about this, of course this cycle is going to be affected by many of the changes we've already discussed. It happens in the context of a person that's a part of a relationship. I want to talk a little more about what those changes might look like in women and also in men. So in women, there can be loss or reduced interest or receptiveness to sexual activity. There can also be changes in sexual arousal, such as slowed or reduced vaginal lubrication or thinning of vaginal tissue. I heard a really interesting story from a survivor the other day when she had gone to a survivorship group and they were playing a game where they said, what was the most difficult thing that happened with treatment? Just really quickly, yell it out. And they both yelled out, vaginal lubrication, at the same time. So this is a big change that's not often talked about. And one of the reasons that this actually happens is because vaginal lubrication is directly connected to estrogen, right? So if there's any change in treatment that has affected estrogen, it's going to lead to a change in vaginal lubrication. It can slow it down or can lessen it. And there can also be changes in the thinning of vaginal tissue that comes with that sometimes. In terms of orgasm, there can be a longer time to reach orgasm. It can take longer. One woman said it took more work. Or it can feel less intense or changed. That's really going to depend, again. There can also be pain with sexual activity. And again, I want to just take a second and look at this whole thing, and you can see how a change in one part of the cycle can, of course, affect another. So if you're having reduced vaginal lubrication that's causing pain with intercourse, over time that's probably going to let you be less interested in sexual activity if it's hurting each time you do it. So of course they're related to each other as well. Possible changes in men. There can be an inability to get or maintain a firm erection. There could also be changes in orgasm. This can be difficulty reaching a sense of climax. There could also, depending on the type of treatment one has received, there can also be changes in orgasm. So there can be something called a dry orgasm. That's where it's like the sense of an orgasm. It feels the same, but semen doesn't come out. And some folks have something where there's a little bit of urine leakage with orgasm instead of semen. And there can also be pain during sexual activity. So one thing that we know for sure, so you're not alone if you've experienced this, is that sexuality and body image changes are very common after cancer. And also know that many patients just never end up talking about this, especially in the context of medical teams and especially in terms of sexuality changes. So there's been a lot of research into why that happens. And I think there's a lot of pretty good reasons for that. And I want to talk about what some of them might be right now. So there are lots of common concerns or worries that can stop us from addressing some of these concerns. And these are thinking about concerns about sexuality. One is that there can be an unstated worry in the partnership about hurting a partner. And this can be physically hurting a partner with their undergoing treatment, or kind of emotionally hurting a partner if we bring it up at all. There can also be, of course, we all always worry about fear of rejection, right? If I bring this up, it's not going to help. My partner's going to turn me down. If I say, hey, let's do this differently, they're going to say no. I've also heard a lot of folks talk about they're worried that if they bring it up at all, they're being really selfish or overly demanding. That's another thing I've heard. I think that lots of folks are worried that medical providers might be made uncomfortable by asking questions about this or bringing it up. So these are some things that I have found that are common ones. I think that another thing that can get in the way, remember Dr. Shumei was talking about myths. There's common myths that we might hold. And I think that there's definitely beliefs that we might hold about body image or sexual functioning that can get in the way of us making changes. So I'm going to go through a list now of some beliefs that you might see come up, and I want you to just gently question them if they come up. They're worthy of questioning. One thing I hear a lot is that I don't bring it up because nothing can be done, so what's the point? It's all due to aging. It's all due especially to premature aging from my treatment, so why would I even bother? That ship has sailed. Another one I hear is, my sex life will get back to normal if I just give it time, if I just wait it out. The research has shown that's true of some other things that happen after cancer. It's not true of sexual functioning. So it might be something where it's more worthy of asking a question, especially if it's going on for a while, as other things are improving. Another thing I hear is it shouldn't be important. It's not important as long as I'm alive. And I hear this in different ways from different folks that I've worked with. I've had folks feel like, oh, if I'm worried about my body image, that seems shallow. A lot of people will use that word. Or I should just be grateful that I'm here to ask for this too feels like a lot. That's something I hear a lot. And another assumption I think folks have is that if there's something going on where it's something in the relationships that's affecting it, my partner would bring it up. Again, that's not always true. That's a hard thing for, I think, most of us to bring up in romantic relationships. There's also more general beliefs or myths about sexual functioning, sexuality to look at. And these are some of them. I hear these a lot. Sex is only for those under a certain age. Only spontaneous sex is good sex. If we have to plan for it or if we have to talk about it, it's not good. Related to, I think, my partner should know what I like or want, or I should know what my partner likes or wants. And this idea that if we really love each other or care about each other, we're going to know what the other person wants. There's also this idea that affectionate touching always leads to sex. I hear this a lot. We haven't been cuddling as much because I don't want to start something that I'm not sure I can finish. I hear that quite a bit. And if you, so those are some of these. And only penetration is sex. That can be something that's on the table too. That's the be all, end all. And the other stuff we do that's physically intimate doesn't count as much. Here are some other common myths. My partner's needs always are going to come first. There's the idea, can be the idea that normal women just have orgasms every time they have sex. A woman's sex life ends at menopause, particularly important for this group where you might be having menopausal symptoms. Not true. A man is always interested in and ready for sex, and a real man is going to perform in sex. So you might see variations of these myths coming up for you. Please notice them because they can get in the way of us looking at changes. Speaking of which, I want to start to talk or introduce some of the things that can help. So one thing I want to say is Dr. Shumay is saying that we have this great team here. And you do. You have this great team. And one thing that is true is the team won't be able to help you if they don't know that it's going on. So you could definitely talk with your medical providers about what might be helpful. And they might talk about things like lubrication. That's something that's used during sex to help with friction and reduce pain. Moisturizers. It's more like a lotion. So you use it regularly, but it doesn't do the same thing as a lubricant. There's also medications or devices that can help. And I want to really emphasize there's a variety of treatment options available, and that it really depends what's going on with you and what you'd like to see addressed. That will determine what the way forward is. So if you ask your medical team, if you ask your oncologist, they will be able to help you, and if they can't do it directly, they'll be able to refer you to folks who can. Another thing that I want to suggest is that when it comes to reconnecting with intimacy and regaining sexual desire, it can be helpful to get to know one's body and begin with a focus on what feels good, what still feels good, what's pleasant, and rather on sexual activity per se. There can be a lot of pressure that's put on sexual activity, and that can cause us to lose connection with the fact that touch can still feel pleasant. Intimacy, physical intimacy can still be good. And so you can start gradually and consider building up to sexually intimate activity if that makes sense. There's also activities you could use to kind of rebuild self-esteem, a sense of mojo is what one of my patients called it. And I think that it's important to identify and then planfully engage in the activities that make you feel good about yourself, and maybe remind you of what your body can do, what it can still do. And especially when fatigue is on the table, that actually takes some planning and some thought to engage in those activities and start doing them again. Also, Diane was talking about, Dr. Shumay was talking about getting outside. Any kind of moderate physical activity that gets you moving can also be something that kind of reminds you of what your body can do and brings back a sense of vitality. So that's another thing that you might consider. Another thing to consider is taking the opportunity to expand your repertoire or change it up a little bit. Experimenting with things that you might not have tried before, particularly if previous sexual routines aren't workable right now. And so you can try things like new positions. Some might be more comfortable depending on what's going on. Extending foreplay can also be helpful. And experimenting with things like fantasy, if that's something that you and or your partner is open to. I also want to give you permission to be more planful about intimacy and about sexual activity. So this is planning ahead for dates or times with yourself. This doesn't have to be physically intimate activity either. It can be just times for intimacy. A lot of folks I work with have spent a lot of their time with their partner negotiating cancer appointments and trying to get here and there. So this can be time to check in with each other or have more of an emotionally intimate time as well. So planning ahead for that, setting dates, and trying to save some energy for intimacy. Doing it at a time of day when you think you'll have the most energy, or if you knew, hey, my partner comes home at this time and sometimes I'm really tired then, but I want to have some time to talk, trying to rest up earlier in the day and do what you can to accommodate that. I think it's also can be useful to, I call it setting the stage. So planning ahead about what you think will make you more comfortable as you're engaging in intimacy. So wearing clothing that makes you feel good or makes you feel comfortable. Creating an environment that feels comfortable. And that can be like setting up the pillows in the way you like or the lighting. And if you have lubrication or devices, making sure it's nearby and handy so it doesn't interrupt the flow in the way it can sometimes. Another thing that can be helpful is really thinking about communication with the partner. I'm experimenting with having clear two-way communication about this. And again, that's sometimes something that happens naturally, but sometimes it takes some planning. So making the time to talk. And if you're interested in having conversations about sexuality with a partner, planning ahead a little bit for that. Thinking about what you might want to say, how you might want to say it. Also thinking about timing can be important here. Sometimes these conversations don't go as well because they kind of come up. We didn't plan ahead. It kind of pops out at a time we weren't exactly thinking of having the conversation. So taking some time to plan can be helpful. And in terms of building intimate activities, surprisingly, a lot of us spend a lot of times on our phones or looking at the TV. So sometimes when folks are thinking about time to build in for intimacy, it can be helpful to think about unplugging a bit. And this, I know that we're running a little late today, so I went a little faster than I would have liked to. But this is something that I invite you to try out today. That is a thing I think you could do pretty easily. If you're here with a partner, you can do it with them, or you can do it alone. But just starting to brainstorm. Starting to identify the types of activity that leave you feeling better about your body or better about yourself, remind you of what you can still do, or identify activities with you and your partner that are shared positive experiences that you might be able to do together, or activities that enhance intimacy. Again, doesn't necessarily have to be physical or sexual intimacy, but any type of intimacy. So this is something that you can start right away. So that's where I will end it for today to get us a little more back on track. But thank you for having me today.
Thank you so much. I am learning so much today. So we are going to go into the break. I know we have the question cards here for you. Dr. Levin and Dr. Shume are around during the break if you want to talk to them and address your questions to them directly. I want to let you know about a couple of things. One is if you haven't signed up for a massage or acupressure, we have the Kashmir Foundation here. They have a table back there. They're going to be here all afternoon. So please sign up, treat yourself to a wonderful massage. The Kashmir Foundation is a partner with UCSF, and they're also offering massages to our infusion patients as well. So we're very grateful to have them. Please take advantage of that. And we're going to take a short 10-minute break. There's still coffee and snacks for you out there. The bathrooms are out there, and we'll see you back here in 10 minutes.